I can just introduce myself. I'm Andrew Fogarty. I'm a clinical epidemiologist, and I'm also a respiratory consultant in Nottingham. And this is a combination, basically, of some of the work I've done with the health analytical community in Nottingham. So I'm going to talk about pulse oximeters, and I'm going to talk about the error in pulse oximeters generally, and then the specific error of the use of pulse oximeters within certain ethnic groups. And I always make the assumption that people know what a pulse oximeter is, but just in case, it's an interesting bit of kit that was developed in the 1980s in particular, and it's crept into medical care now, so that it's used ubiquitously. People have got them at home, GPs use them, nurses use them, and we use them on the wards because they give you a continual reading of the oxygen saturation in the blood without any needles or blood tests. So it's good for patients like it, no needles. Staff like it, no blood tests, no infection control issues. Now, the principle of the pulse oximeter is that it sends two infrared beams through a translucent bit of tissue, normally a finger. The beams go through, and due to differential absorption of the light beam by oxyhemoglobin and deoxyhemoglobin, which is effectively the oxygen in the blood, you can get an algorithm that gives you an oxygen saturation in the blood. The problem, as you're about to see, is that these were developed in Japanese and Caucasian individuals. And so the light beam is great in people with light skin because it goes straight through. But as soon as it goes through darker, more pigmented skin, the melanocytes disrupt the signal. It goes all over the place and it's messy. And this has got clinical implications, as you're about to see. So during the COVID pandemic, as you're all aware, the whole sort of world felt like it had broken for a certain period of time. There was a lot of anxiety, there was a lot of uncertainty about the future. And in Nottingham, it allowed a combination of people to get together who wouldn't have otherwise been chucked together. And they were statisticians, epidemiologists, the management were involved. And then importantly, people we'd never met before, by which I mean the health analysts and the data warehouse people, all got together and said, what do we want to do and how can we do it? And they developed a machine or a device or a database that was actually designed for predicting the demand for medical intensive care beds, because there was that horrible sort of, I don't know, 6 weeks when you didn't quite know where the curve was going to keep going up and hit the ceiling, or it's going to go up and come down again. But then it became apparent once this thing had been developed that it could be used for other ways to understand the disease that was unknown, strange, and seemed to be killing people from non-white ethnic groups more than people from white ethnic groups. I've got to give you a little refresher on respiratory physiology, just in case you're not aware of it. The respiratory rate, which you're about to see in a minute, is the engine of breathing, and you'll know that from personal experience. If you go up some stairs or run, you breathe harder. But equally, if you've got horrible COVID pneumonitis or pneumonia, you breathe harder as well because you can't get the oxygen in it. It's a sick person's equivalent of running upstairs. The second thing is oxygen saturation. The oxygen is carried in the blood by hemoglobin, and there's two ways of measuring it, which allows us to look at the error. First is the pulse oximeter, which, as you've gathered by now, may not be perfect. And then secondly, there's an arterial blood gas, which you do when you actually stick a needle into an artery, sample it, and that gives you the true gold standard real oxygen saturation, what's going on. And because we had huge volumes of patients with concurrent pulse oximetry, because it's been done anyway, and then arterial blood gases, we could look at the measurement error of the pulse oximetry by comparing it to the gold standard of the arterial blood gas. Does that make sense? That's the fundamental principle here. Pulse oximetry against gold standard. So just to get your eye in on this graph, the bottom axis is the true arterial saturation from the arterial blood gas. So this is the real deal. The y-axis is the pulse oximetry measurement subtracted from the true gold standard measurement. So if the pulse oximeter was 100% reliable, there would be all of these values here would be straight across the middle. As you can see, if it goes up, then the pulse oximeter is overreading. If it goes down, the pulse oximeter is underreading. And first of all, if I can draw your attention to here, this is the 90 to 100% window. This is when you're normally okay. And as you can see, the pulse oximeter is pretty good there. And it's interesting, it was validated and it was used in this population, which is why we all thought it was okay. But as you get down into the 80s, and this is what I call the clinical decision-making zone, and particularly between 85 and 90%, then the measurement error in the pulse oximeter starts to go up quite appreciably. And this is the area where me, with my respiratory consultant hat on, makes a decision as whether to increase the treatment, escalate to intensive care, or say you're going to die and put them on a palliative care pathway. So it's vital that the measurements are accurate here, and yet they're not. And this, I just want to clarify, is in everybody. We haven't even got to the ethnic minority group problem yet. So in all of us, there is an issue with the pulse oximeter not being as good as doctors, myself a respiratory consultant nearly 20 years, previously thought. The MHRA, who regulate these things, previously thought that the pulse oximeter was pretty good. Their website suggested that the true value of the measurement error should be 4% or less. But going back to the graph, that's what the MHRA thought that was going on. And as you can see, the measurement error of the pulse oximeter, as the oxygen saturation goes down, is appreciably higher. So moving on to people with non-white skin, the fact that pulse oximetry measurements error in people with dark skin has been known for decades, although it hasn't really been very well publicized. This paper in the New England Journal of Medicine kicked it off in 2020. And in essence, because there's bigger populations of non-white people in the States, these researchers were able to look at the number of patients who appeared to be all right, because the pulse oximeter said their saturations were okay, but they weren't all right because the oxygen saturations, the true measurement, weren't. So they used a similar paired method to ourselves. And they showed that the issue of appearing to be all right but not being all right in people with white skin was about 4%. But if you had black skin, it was threefold more. And this is the paper that really kicked it off, and we sort of nicked to a large extent. Now, we then moved on to ask the same question in Nottingham. Does pulse oximetry measurement error vary across ethnic groups? And I'll just talk you through our data with a few specific examples just to highlight the salient points. First of all, in the overall difference, the pulse oximeter in the white group error is about 3, and you can see it's appreciably higher in the black and Asian groups. But that's not the most important thing, because you want to know what the error is in the zone when doctors make the decisions which can make all of the difference. So that moves down to here, the clinical critical decision-making zone, as I tend to call it. And in the white patients, we've got about a 2% error, and it goes up to 4 and almost 6 in the black and Asian populations. And the implication there is that if you're going along with a real saturation of 88%, some of the Asian populations could actually be 94% on the pulse oximeter. So people like me think they're okay when they're not. This is just for the statisticians. We adjusted for all sorts of things, and the effect remains there. So it's not due to confounding by other things. So we've shown pulse oximeters aren't as good as we thought they were. We've shown that the problem's bigger in people with non-white skin. Then the important question is, could this have actually negatively impacted on the delivery of care to people from non-white ethnic minorities? It's a disturbing question, really, because people from non-white ethnic minorities who were dying more during the pandemic than people in white groups, particularly in the first wave. And it's potentially the fact that we might well have been complacent because we were relying on these flawed tests, which may well have meant that people from with non-white skin got later timely care. I've shown you the problem, so I won't go through it again. So we then looked at the patients who were transferred to intensive care from the wards stratified by ethnic group. And if they're all getting the same amount of medical care at the same level, then all of the numbers should be similar. But I'll just talk you through what actually did happen. I just want to point out actually at the top, we haven't got many non-white people in Nottingham. You can see this from looking at the numbers. There's 400 white, 48 black, 53 Indian Pakistani. And the fact we were seeing statistically significant differences in such small numbers means it's a big effect. So first of all, the pulse oximetry. These are the patients who went from the wards to intensive care. 94, 94, 94, 94, 94. So they all look the same from a pulse oximetry basis at the point of transfer. And that's the time when someone like me calls the intensive care consultant and says, could you come down here? This person's not doing very well. We need to sort of salvage them and support them. However, the real oxygen saturation at point of transfer was 94.4 for the white population, 93 for the black, and only 91.6 for the Indian Pakistani. So the pulse oximeters were basically lulling us into a false sense of security, and we were referring people with non-white skin later than people with white skin. From a respiratory point of view, it's particularly disturbing that the white people had a respiratory rate of 26. That's the engine of breathing to try and sort of stay alive, while the poor black and Indian populations had a respiratory rate of 31 and 30, and that's a huge increase above. So they had to work much, much harder to still be sicker. Does that make sense? I presented this a few times to nurses, and they're often in tears by this point because they actually remember how the non-white people seem to be much more uncomfortable than white people, but nobody really understood why at the time. Again, it's not due to confounding, it's a real effect. So the implications here are that any decision to use a pulse oximeter may discriminate against people with non-white skin. That's admission to hospital, that's starting oxygen. The dexamethasone, which decreases mortality by 18% or more, is linked to starting oxygen, which means these people getting dexamethasone later, that's the big recovery study that happened in the UK that everyone was very pleased with, it actually had a built-in delay for people with non-white skin. Starting Toki, which is a drug we start for bad COVID, also is linked to oxygen, which means that people with non-white skin get it later. And it probably applies to other respiratory diseases as well. In people who are dying, we often give them oxygen at the end stage of their diseases. And when we looked in Nottingham, the people who got oxygen for end-stage lung disease, those with white skin had much higher oxygen saturations than those with black skin, possibly because the pulse oximeter had again lulled the doctors into a false sense of complacency. So just checking my timings. Yep, okay. So the problem I had, and it was about 2 years ago, and is now we know this thing, it's really, really important. How do you get it out there? How do you share it? How do you disseminate it? And it's really frustrating, to be honest, actually, because we published the papers, but no clinicians or nurses or healthcare people or ambulance people have got the time to read them. I've done a variation on this talk about 12 times now, and every time at the end of it, when I do it to clinicians around the Midlands or in London, people come up to me going, oh my God, that's awful, I didn't know that. And I was thinking, well, you know, I've known it for 2 years. And in fact, it's interesting, the Nottingham health analytic community know a lot more about this than most frontline clinicians around the country. It's really difficult to break out. We then thought about social media. I contacted Chris Whitty, who was at my year in medical school, and said, well, what do you think of this? And he just said, well, keep disseminating the information. So we then thought about an educational cartoon, which I'm just going to show you, which is something we've done to try and increase the spread and reach of this. So if you just bear with me, this will last about 5 minutes. It will tell you some of the stuff you've already seen. It's based on the talk I've got, and it's just our effort to try and spread the word.
As healthcare professionals, we use pulse oximeters to measure blood oxygen saturation levels for all of our patients. The information that pulse oximeters give us on oxygen saturation informs virtually all of the decisions we make for patients coming into hospital with respiratory conditions.
What we're learning, however, is that this information has limitations, and pulse oximeters can make errors that particularly affect people with darker skin tones.
Hi, my name is Andrew Fogarty, and I'm a respiratory consultant in Nottingham.
My name is Orestia Giacomo, and I'm a respiratory trainee based in Nottingham. To start with, some background. Pulse oximeters work by passing infrared beams through a translucent tissue, usually a finger or an earlobe, and measuring the difference in absorption of those beams between oxygenated and deoxygenated hemoglobin. We know that the high levels of melanin found in more pigmented skin can affect this measurement.
Of course, the American study, published in 2020, the gold standard as measured by arterial blood gases with the oxygen saturation measured by pulse oximetry. They looked for what they call hidden hypoxemia, which is defined as a pulse oximeter giving a reading of equal to or more than 92% oxygen saturation, or the true reading from the arterial blood gas was less than 88%. They found that hidden hypoxemia was present in 6% of people with white skin, but in those with black skin, it was present in 17%. In other words, black-skinned people were almost 3 times as likely to have hidden hypoxemia than white people.
During the height of the COVID pandemic, we conducted a study comparing pulse oximeter measured blood oxygen saturations to arterial blood gas measured blood oxygen saturations in patients admitted with COVID. We found that if a person's blood oxygen saturation was below 90%, pulse oximeters gave an estimate of the blood oxygen saturation that looked better than the true reading which was measured on an arterial blood gas.
We also found that similar to the American study, the discrepancy between blood oxygen saturations measured by pulse oximetry and arterial blood gas was higher in people who were black or Southeast Asian origin.
We then asked whether this could have led to a delay in escalation to intensive care. We found that the median blood oxygen saturations measured by pulse oximeters were 94% on arrival to intensive care, regardless of skin colour. In other words, guided by pulse oximetry alone, people referred to intensive care had roughly the same level of blood oxygen saturations.
However, we found that individuals who had darker skin had higher respiratory rates on arrival to intensive care, meaning that they were sicker. And then when we looked at their arterial blood gas, the true oxygen saturation as measured by the arterial blood gas was actually lower in people with darker skin compared to those from white ethnic groups. So the implication of this is, despite pulse oximetry suggesting that everybody had a similar level of oxygenation, in reality, people with darker skin had lower oxygen levels and were more unwell with higher respiratory rates, point of admission to intensive care than white people.
So to summarise, we found that pulse oximetry overestimates blood oxygen saturations in people with true oxygen saturations less than 90% as measured by an arterial blood gas. This error is greater in people who are black or of Southeast Asian origin than in people who have white skin. Worryingly, this may already have led to people who have black skin and people who are of Southeast Asian origin arriving in intensive care with lower blood oxygen levels than people who have white skin during the COVID-19 pandemic.
Taking everything into consideration, these data suggest that every clinical decision that uses a pulse oximeter could discriminate against patients with non-white skin. For patients with COVID, this includes decisions on whether they need to be admitted to hospital, whether they need steroid tablets or antibody therapies, how closely we monitor and how quickly we escalate transfer to intensive care.
So what can we do about it? In the short term, we can do what we're doing now, which is sharing the knowledge that pulse oximeters can overestimate blood oxygen saturations, and that this is going to be a particular problem for people who have darker skin. In practice, we need to pay careful attention to other signs of how unwell a person might be, such as looking at their respiratory rate, and if in doubt, do an arterial blood gas. In the longer term, we need to wait for technology firms to build in ways for correcting for this error. But obviously, it will take time for this to become available.
If you found this video interesting and like to read more about this research, we'll put the links and references in the text below. We'd also appreciate it if you can share this with anybody else who think they benefit from watching. Thank you very much for your time.
Sorry, I've just got to get out of this. Next. Yep, I'm good. So just to summarise, pulse oximeters has got more measurement error in measuring the oxygen saturation than many clinicians, including myself, appreciated. It's worse in people with darker skin tone, and it looks likely that this measurement error will have contributed to the increased mortality that people with darker skin had at the point of transfer. So they were more sick at the point of transfer, and it may well have contributed to the increased mortality that people with darker skin had from COVID, especially during the earlier stages of the pandemic. I'd just like to say thanks to the team that did it, really. I'm the epidemiologist who came along at the end, who's presenting it, but this was a huge amount of work by lots and lots of people. There's an ongoing project, and I also just say thank you to anyone who looked after the COVID patients during the pandemic as well, because in essence what we're doing is benefiting from their labours. And if anyone wants a copy of either the slides or the cartoon, if you email me, I'll send you it. Part of my job's really to try and disseminate it now, as I think you've noticed.
Thank you, Andrew. We've got about 5 minutes for questions. Does anyone have a question? Yeah.
Thank you very much. That's really interesting work. Really important to know about. Noticed that there was a difference in between the Asian and the Black group, and that it was more in the Asian group. So I think it's actually quite a broad spectrum of skin colours during ethnic groups. Now, could really use ethnic groups as a comparative data as opposed to any kind of measurement of skin tone?
Yeah, that's a very good question. So there was a session yesterday by the ONS on sort of accurate sort of measurements and phenotyping of ethnic groups. In essence, these people, when they came in so sick, I suspect the nurse looked at them and thought, right, you're Southeast Asian, you're Black. Some of them were mixed, we don't know what mixed is. And then others were white. So we just took what we got basically, which was a tick on a entry form on someone who had more important things to be concerned about and ask what ethnic group they were at the time.
I mean, in terms of the technology, you may not be aware of this, and I don't know if anyone else is, but there's hair removal devices that use like impulse light, and they actually measure the skin tone before they do the exam.
Yeah, no, we're looking at doing a study in Cuba. There's got such a broad spectrum of skin pigmentation in Cuba, and we're looking at well, the one we looked at is called the colorimeter, at £3,000 each. But it seemed very good. Any questions?
Is it very meaningfully by sort of making model process? Are there better and worse ones that depend on like the sensitivity or?
I think the scary thing is nobody actually knows, because we sort of came across this by accident. You know, I'm not trying to say we went into it looking for it. It sort of just happened. So we don't really know. I mean, there's a 5-channel pulse oximeter and a 2-channel pulse oximeter. The 2-channel one is the one the NHS were handing out, comes from China, and then the 5-channel one is like 500 quid. There's one that's used in the hospital, but the stuff I've showed you is the good stuff. So the worrying thing is, it might be cheap stuff, there might be even worse. I mean, some pulse oximeters are about 12 quid. Okay, sorry. Yeah.
So I was just thinking, when I was in uni, you'd see not only pulse oximeters, but also an indication of quality of the reading, because all these idiot babes are fucking around so much, not being with patients and saying still that the oximeters in the same place. I was just wondering whether does that give you any kind of collaboration to say, because all you get is a point estimate. Are you seeing a difference in the kind of quality of the reading that might give you a broader indication of how reliable that reading will be?
No, I know what I'm talking about. When we get someone who's super sick and they've got low blood pressure, the perfusion is such that the signal comes and goes, and that's, I think, what it's designed for. But we actually get really good signals from people who've got black and brown skin. It's just, they're too high, they're wrong. So you yourself?
Yeah, I mean, I think the first kind of comment, obviously, for Manchester, got a very large black and American population, so I can kind of help get us into the system if that's helpful. I guess my main question was, if there's a understanding about there's a kind of physiological reasons in the first slide that you showed why these things work better or not in certain types of skin type, and there's already been some studies, albeit from America, which shows this. Why has it taken so long for that? That evidence to feed into the guidance about is it the perception that there's no data, or is it just the perception that the data's not good enough? So what's the kind of lag? Why has there been such a timeline between what seems very obvious?
So I've been asked that question loads of times, and my opinion is this stuff was developed initially for American pilots for high altitude in the Second World War to see if they're going to conk out with low oxygen levels. Then it drifted into medicine via Japan in the 80s, validated in white and Caucasian populations. Then it was validated in intensive care, because everyone's on lots of oxygen there, so they're always 90 or above, and it looks all right. And it's only now, when we had a pandemic, when we had lots of paired samples of different people, that we could see that this test wasn't as good as we thought it was. And I just looked at the numbers, and until 2 years ago, I didn't even question them. You don't look at a number and think, is that wrong? You look at the number and do something with it.
Yeah.
And so the regulators may well, you could point the finger at them and say, well, you should have done better, but the whole medical establishment embrace pulse oximeters because they're so convenient and they're so easy and they're so applicable in so many different
kind of pipe effect that everyone kind of follows.
And scarily, just as an aside, the infrared thermometers which point at your head look like they might give different readings of the colours of the skin as well, which is the next one I think potentially. So did you have a question? No.
Just with the rollout of pulse oximeters as a tool for ambulances, should we be putting in an additional step in the ambulance kind of triage pathway to say it's that reading on the pulse oximeter, but have taken into account the wider patient from these backgrounds? Should you have a higher threshold for black and Asian backgrounds than the white backgrounds?
I think that whoever the healthcare professional is, they need to be aware that they may be error in signals at certain points, and then that's what you can't. It can't be that critical. The error is quite big, and it depends on where you are on the as well.
Okay. I've got one more question. I want to ask for an impact architect. I don't know a simple way of getting a lot of information. Particularly this age, it's a free hospital community, but they don't even like that. Good for not very patient.
And I'm trying to do the is right at the centre of the moment, actually, thinking how to work.
Well, thank you so much. It's been absolutely fascinating today. Thank you, Andrew.
Yeah, nice to see you.
Yeah. What time are we?